My name is Avanish Harish. I'm studying third year MBBS from Bangalore Medical College and Research Institute. Today I'll be presenting a case of exposure keratitis. Ma'am, I'll start presenting the case now.
Yes, you can start.
Okay. Ma'am, so my patient's name is Mr. XYZ, who is 45 years old, living in Hebbal, Bangalore. He is a Pani Puri seller by profession. He was examined on 2nd September 2022. He presented to the OPD with complaints of pain in the left eye since 2 months, headache since 2 months, watering in the left eye since 2 months. Patient gives a history of stroke 2 months ago. He complains of pain in the left eye since 2 months, sudden in onset, non-progressive and continuous in nature. It was of the stabbing type and there was no radiation to any other side. It was aggravated by viewing bright light and not relieved by any medication. It interferes with his daily activities and is associated with watering of the left eye and headache. Patient also came with complaints of headache since 2 months, which was sudden in onset and progressive in nature. It started in the left temporal region and then subsequently spread throughout the entire scalp. It was also of the stabbing type. Diurnal variation was present where it was more in the evening.
Okay, let's stop at this. Just go back to your previous slide. Okay, so based on your demographics, occupation, and the complaints like pain in the left eye since 2 months. So what are the causes of pain in the eye?
Ma'am, pain in the eye can be divided into 2 causes, ocular and systemic causes. Ocular causes can be due to any mechanical trauma, infections like allergic and conjunctivitis, keratitis, glaucoma, congestive glaucoma, iridocyclitis, uveitis, endophthalmitis, and panophthalmitis. Systemic causes can be any meningitis, intracranial tumor, intracranial space occupying lesions, and then
right. So based on these causes, ocular causes, any specific, like if the pain is more during the night, can you think of any particular cause? Generally, your uveitis is the pain is more during the evenings, and
yes,
other pains are like throughout. And of course, what are the ophthalmic causes of headache?
Ophthalmic causes of headache, any conjunctivitis, keratitis, uveitis, glaucoma, iridocyclitis,
right.
orbital
So basically, more causes of headache would be glaucoma, your keratitis and uveitis. Generally, conjunctivitis, we don't have so much of headache. So whenever we have headache, it is more likely that we are dealing with the case of narrow angle glaucoma or uveitis or something deeper. Okay, fine.
Yes.
So your the pain has been progressive. It is non-progressive and continuously it is present.
Yes,
okay, no radiation to other sites. So what does this radiation to other site mean? Like where do you expect it to radiate?
Ma'am, to the occipital region, then even to the sinuses like bridge of the nose,
right.
supraorbital region, as well as to the maxilla, ma'am.
Okay. And what are the non-ophthalmic causes of headache where the pain patient presents sometimes to the ophthalmic department?
Ma'am, meningitis, yes. Intracranial space occupying lesions, then any head injury.
Yes. Okay.
And
yeah,
as well
migraine. So Aditya
migraine.
is replying migraine. Yeah, migraine is a good answer because there are some causes of headache where a particular type of migraine called ophthalmoplegic migraine, where the eye is particularly involved. So that is another important cause where patients present to the ophthalmologist first. Okay, so we can move ahead to your next complaint.
So the next complaint, patient also has watering in the left eye since 2 months, sudden in onset and continuous. There was no diurnal or postural variation. It was not relieved on taking any medication. It was associated with redness of the eye. Blurring of vision in the left eye was observed by the patient.
So what are the causes for watering?
Ma'am, watering can be of two types, either due to excessive secretion by the lacrimal glands, which is hyperlacrimation, or it can be due to decreased outflow, that is called as epiphora. Hyperlacrimation, central causes can be due to emotional states, stress, etc. Peripheral causes of hyperlacrimation can be any tumors, lacrimal gland tumors, lacrimal gland cysts, parasympathomimetic drugs. Then there is also conjunctivitis, keratitis, corneal ulcers, abrasions, uveitis, iridocyclitis, congestive glaucoma. And ma'am, then causes of epiphora are occlusion of the punctum, eversion of the punctum due to blepharitis or conjunctivitis, punctal occlusion due to stenosis or any stricture.
Okay, you can actually tell it as in the beginning, you can tell any blockage of the lacrimal drainage apparatus. Okay, when you're answering, don't go into everything individually. Grossly, will tell blockage in the nasolacrimal drainage apparatus, and then go into punctum. So in the punctum, punctal occlusion. Okay, and later after your punctum comes your
punctum, then there is a lacrimal sac. So under that dacryocystitis, lithiasis, and even stricture or fibrosis of the lacrimal sac, sorry. Then nasolacrimal duct obstruction due to non-canalization or incomplete canalization.
That is in children. In adults?
Ma'am, in adults, fibrosis due to radiation exposure,
blockage of the nasolacrimal
infection, inflammatory causes, ma'am.
Okay. Can you think of any lid causes, eyelid causes for epiphora?
Ma'am, ectropion.
Right, ectropion. So you can, if the position of the punctum is altered, if it's the punctum itself is not opposed, you can have watering even then. Okay. Yes, so yeah, go ahead. Are there any other complaints?
Ma'am, just blurring of vision in the left eye was observed by the patient along with glare. Other than that, there was just no other complaints, ma'am.
Okay, so blurring of vision, it is now a painful blurring of vision with headache and watering. So what can the causes be?
Painful blurring of vision with watering. Ma'am, it could be, first thing is keratitis, corneal ulcers, abrasions, neurotropic ulcers, as well as exposure keratopathy. Then there is also congestive glaucoma,
right?
Congestive glaucoma, iritis, cyclitis, and iridocyclitis.
Okay.
Then
so all these causes. So this is like more like a painful diminution of vision. Okay.
Yes, ma'am.
Yeah. So you have mentioned floaters, colored halos, photophobia, all that. Why is that?
Ma'am, to rule out retinal causes of blindness, mainly posterior segment causes of blindness.
Okay, and colored halos?
Ma'am, colored halos for ruling out any central corneal opacities or cataract, ma'am. Basically, they cause colored halos due to diffraction of light.
Okay. So what are the causes of photophobia?
Photophobia, corneal opacities, macular edema, macular...
Corneal opacities or corneal acute lesions, okay? Opacities are generally... Yeah. Okay. Anything which where the epithelium is absent. Okay.
Yes, ma'am.
Fine. Day-night blindness, diplopia and all, not very relevant for the case. Okay. And why have you asked history of discharge or the protrusion?
Ma'am, to protrusion mainly to rule out thyroid ophthalmopathy.
Okay.
And discharge, ma'am, to rule out any orbital cellulitis or orbital emphysema, dacryocystitis, any associated infective conditions in the vicinity of the eyeball.
Basically, if there is any discharge, it means that there is a slight infection. If it is clear watering, it may be epiphora or hyperlacrimation. But the moment you have discharge, we have to be a little worried because it means that there is some organisms that are involved. Okay.
Yes.
Go ahead with your past history. Other students, just notice that we have put in the case sheet picture only. We haven't used a PowerPoint slide so that you can know how to write the case sheet. Okay. So do leave a neat margin and write legibly when you're writing your case sheets. Many a time, some examiners will ask you to present directly. Some will allow you to present it from the case sheet. Nevertheless, you should be well versed with presenting without the case sheet in your hand. Okay, okay. Go ahead with your past history.
Ma'am, past history, ocular past history, he does not have any history of spectacle or contact lens use or no prior ocular medication or surgeries. He had a history of stroke 2 months ago, for which he initially took Ayurvedic treatment for 1 month, but the symptoms did not improve. Later, he received an injection at an hospital, which was given after 1 month. He was also diagnosed with hypertension 1 month ago. He's not a known case of diabetes mellitus, bronchial asthma, TB, or epilepsy. No known allergies, ma'am.
Okay, so the moment the stroke of 2 months history, what are all the problems, ocular problems that a patient with stroke can have?
Ma'am, first one is he can have a sudden painless loss of vision due to
Yes.
decreased vascular supply to the retina. Then subsequently,
To
he
the
can
retina
also have
or to
exposure
the
keratopathy.
something else? So what you mentioned is very good, but decreased blood supply not to the retina, but something in the brain.
Occipital cortex, ma'am.
Right.
Occipital
So
cortex.
anywhere in the brain which involves the visual pathway. Okay. So with that you
Yes.
can have decreased vision. More so we can tell field of vision. Okay. Since the entire visual pathway extends from the eye through the brain, through the temporal lobe, parietal lobe, and to the occipital cortex, you can have hemianopia. Yeah, Aditya is mentioning homonymous hemianopia. So you can get a homonymous hemianopia based on the location, whether it's in the tract, whether it's in the radiation or the occipital cortex, different types of hemianopia will be there. Okay, one is the hemianopia. Then what else can you have?
Um,
More so, let's take it as a CNS case. Any CNS abnormality, what are the ocular manifestations? So one we know is the visual field defects. Other manifestations? Like if the fifth nerve is involved, so lag of thalamus is one, that is the seventh cranial nerve.
Yes, ma'am.
So other cranial nerve involvement can be there. We'll discuss it in the CNS examination. Okay.
Yes, ma'am.
Okay, sensation loss, yes. So the fifth nerve, if it is involved, you can have a sensory loss. Fine. Okay. And yeah, let's wait. What are the ocular manifestations of hypertension in the eye?
Ma'am, sudden gradual painless loss of vision.
Right, very good.
Then
In the form of vascular occlusions or
vascular occlusions.
Yes.
Ma'am, then even chemosis.
Right.
Chemosis. Ma'am, then sometimes you can have also ecchymosis due to rupture of the blood
Very
vessels in
good.
the
So yeah,
conjunctiva.
subconjunctival hemorrhage, vitreous hemorrhage. Yes.
Vitreous
So
hemorrhage,
those are all
retinal
the
detachments.
yes. So these are all the manifestations of hypertension. And also these hypertensive patients are more likely to have glaucoma. So like glaucoma is more common in people with hypertension. Surgically, if at all a patient has to be taken for surgery, how does hypertension affect the particular procedures?
Ma'am, this one, it can hypertension is a risk factor for developing expulsive choroidal hemorrhage
Very good.
during eyelid eye surgery or orbital any orbit surgery. So that one, if the blood pressure is not controlled prior to the surgery, then there can be loss of this expulsive hemorrhage, and that can lead to loss of the eye and even a worse prognosis. Ma'am.
Yes. So this is general discussion, okay? Whether it's a cataract case or your corneal case, this is how your past history will be discussed. So we are discussing it like that. And so similarly, what are the ocular manifestations of diabetes?
Ma'am, ocular, it can be divided four types. Non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, then diabetic macular edema, as well as advanced diabetic eye disease.
Okay, so that is the diabetic retinopathy is one. Then in cataract case, how does diabetes?
It is, I think,
Yes.
snowstorm cataract, if I remember correctly.
Snowflake cataract. So
Snowflake.
it can cause a snowflake cataract. It can also cause early progression of a senile cataract. Then for surgical considerations, how is diabetes relevant?
Ma'am, diabetes is an immunosuppressive state.
Very good.
So risk of infections are high, and in case the sterile procedures are not followed due to inadequate sterility in the OT, then there is risk of infections, endophthalmitis and panophthalmitis.
So
Then
additionally, you can also have Aditya is mentioning infections of the lid, higher post-operative infections. Yes, very good. And also vascular occlusion, similar to hypertension. You can also have vascular occlusions. So similarly, what are the manifestations of bronchial asthma, like eye manifestations in a bronchial asthma patient? Why is that history relevant?
bronchial asthma. Ma'am, in
Allergy.
case there is any thinning of the conjunctiva or thinning, any surgeries that lead to weakening of the
Basically,
sclera or the
these
cornea.
patients are more prone for allergy, so allergic conjunctivitis. And what is the mainstay of treatment, systemic treatment in bronchial asthma? Some drugs which can affect the eye.
Ma'am, beta blockers, no?
Beta blockers, yeah. So that is one thing. So let's say if your patient is a case of glaucoma, then definitely you have to take into consideration that this patient is a bronchial asthma patient. So you have to take due precautions whenever you should not be giving them beta blockers, or else you have to give selective beta blockers and steroids. So if these patients mostly will be on steroids, so what are the manifestations of steroids on the eye?
Ma'am, topical application, if you do, then it is glaucoma. If it's systemic, then it can lead to cataract, ma'am.
Right. So glaucoma and cataract. Okay. So this is how the questions will be asked based on your past history. This is relevant for all cases. Okay, go ahead.
Okay. Next. Ma'am, he has a mixed diet, normal appetite, sleep that is disturbed due to the headache, bowel and bladder functions are normal. Should I continue ahead? Or?
Yeah, at the end of your, once you end your history, you have to summarize the history and give a probable diagnosis.
Okay, ma'am, should I summarize it now?
Yes, summarize your history.
Ma'am, so here is a 45-year-old male who is a known case of stroke 2 months ago. He presents in the OPD with complaints of headache, blurring headache, watering in the left eye, as well as pain in the left eye since the past 2 months. This one is sudden in onset, progressive, non-progressive in nature, and continuous. It is of the stabbing type. It is Ma'am, he's not a known case of DM or hypertension or TB. So based on these findings, clinical findings, not clinical findings, based on the given history, I feel that he might be suffering from either exposure keratitis, then
some corneal affection you
corneal
can tell, because
pathology.
right now at this stage we will not know the function. So it could be either definitely cornea is involved because there is a pain, there is watering. It could be uveitis also. It could be, considering stroke, it could be the corneal affection, either a neurotropic ulcer or a exposure keratopathy. Okay. Go ahead with your general physical examination.
Ma'am, so here is a 45-year-old male who is conscious, cooperative, alert, well-oriented to time, place, and person. He is moderately built and well-nourished. Ma'am, vitals, pulse rate is 90 beats per minute, which is regular in rhythm and normal in volume. 14 cycles per minute respiratory rate. Temperature, he was afebrile. Blood pressure was not measured. On
Okay, how is
head-to-toe
the
examination
of pulse important in an opthal case? Why is it important? What are the conditions where you need to check the pulse? You already mentioned, no, beta blockers.
Yes, ma'am. Beta blockers. Yes, ma'am.
So whenever you are prescribing beta blockers, you should know the pulse rate. So if at all somebody is having a lower pulse rate, again, beta blockers can't be given. Yeah, fever will increase the pulse rate. Yeah, so that is one thing. So respiratory rate also for prescribing beta blockers, you have to check the respiratory rate if there are any other issues. Yeah, cardiac conduction abnormalities. So basically, for giving beta blockers, we need to know about that. Okay, head to toe examination.
Ma'am, on head to toe examination, hair was normal in texture and color. Eyes did not show any signs of pallor or icterus. In the nose, there was loss of nasolabial fold on the left side. In the oral cavity, there was no signs of pallor, icterus, or cyanosis. In the neck, there were no signs of lymphadenopathy. No signs in the hands and fingers, no signs of pallor, icterus, cyanosis, or pigmentation. Chest and abdomen examination were normal, and legs also did not show any period edema. It's blocked here.
Yeah, so generally head to toe examination in an ophthal case, you can also skip, but we have included basically because it's the patient is also having stroke. So otherwise in your cataract case, you can just go ahead directly with your systemic examination. Yeah, go ahead with your system.
Go ahead. Ma'am, ocular examination, head posture, he was deviated towards the left. Ocular posture was normal. Facial symmetry, when we examined, it was asymmetrical with loss of wrinkles on the forehead on the left side, loss of nasolabial fold on the left side, deviation of the angle of the mouth to the right side, ma'am.
Okay, so what are the causes for the abnormal head posture?
Ma'am, head posture can be of three types, ma'am. It can be either a head tilt, head turn, or head elevation or depression. Head tilt was mainly due to paralysis of any of the two oblique muscles, superior or inferior oblique, most commonly superior oblique. Head turn is due to paralysis of the medial or lateral recti. And head elevation is seen in case of ptosis, paralysis of the elevators, overactivity of the depressors, while head depression is seen in cases of overactivity of the elevators and paralysis of the depressors.
Very, very nice. So basically, whenever any question is asked, you can give an introduction. Like instead of directly going to the answer, you can tell it like this. Head posture can be of three types. So then the examiner will know, okay, this person knows about these causes. So then they will just go ahead with the ocular posture. So that's how you have to answer. Like we discussed earlier, what are the causes of watering? So instead of telling conjunctivitis, keratitis, like that, you can tell the causes of watering are two types. One is epiphora, one is hyperlacrimation. So like that, the answering should be a very systematic way. So then the examiner will move ahead to the next question. Okay, right. So here in this particular patient, sometimes patients who want to avoid light also, they will keep their head posture turned away from light. So that is another reason. Okay. So why is that facial symmetry like that? What does it indicate?
Ma'am, it indicates that there is weakness of the facial muscles. So most likely there is involvement of the seventh cranial nerve in this case.
Right. Okay. So go ahead with the ocular examination.
Ma'am, so first visual acuity, distant vision by using counting finger test was 6 meters on the right eye and 1 meter in the left eye. Projection of light rays were normal in both. Near vision was not measured, was not examined.
How do you generally check the distant vision? What is the generally recommended method of testing visual acuity?
Ma'am, best method is Snellen's chart, ma'am. Snellen's distant vision chart. That you place a person 6 meters away from the chart, and then you ask him to read the different alphabets or numbers that are present there on the chart. Otherwise, in general clinical settings, what we use is the counting finger test, where initially we stand 6 meters away from the patient and ask him to ask him to close one eye, and then count the number of fingers that are present. Then if there is patient is unable to see at 6 meters, then you slowly progressively decrease the distance by 1 meter. That is, go to 5, 4, 3, etc. And ask him to keep checking trying to guess the fingers that are being shown to him or her. Then after that,
generally, whenever possible in your exams, if there is a Snellen's chart that is available, do check the vision on a Snellen's chart. If this case has been taken at bedside, so in such a situation, you still mention counting fingers. Okay, instead of writing 6 meter, you write counting fingers at 6 meters or counting fingers more than 6 meters, like that. Okay, what is the importance of projection of light rays?
Ma'am, that basically tells us about which field of the retina is affected or normal. And it also talks about any old retinal detachments, scars, tears, or other pathologies in the retina. It helps ruling out and coming at a better idea of the extent of disease that is present in the eye.
Okay. Okay, go ahead with your eyelids.
Eyelids, ma'am. Position of the right eyelid was normal, whereas the left eyelid was at the level of the superior limbus. The skin over the eyelids were normal on both sides. So were the eyelashes and the margins. Palpebral aperture width was 10 millimeter horizontal into 10 millimeter vertical into 30 millimeter horizontal in the right eye, while in the left eye it was 20 millimeter vertical into 30 millimeter horizontal. Lid closure was present in the right eye, but it was absent in the left eye.
Okay, one more thing before we go into your eyelids, like what exactly are you meaning by ocular posture?
Ma'am, ocular posture is the ma'am, normal ocular posture is where the visual axis of both the eyes are parallel to each other and directed straight. So this one is measured, elicited mainly by looking at the light reflex on the eye by shining a torchlight over the glabella and checking the light reflex.
So that test is called
Shining
Hirschberg's test. So in this case, is it relevant? The ocular posture, very, very relevant because it rules out any. Yeah.
Because since he's had a history of stroke, it rules out any involvement of the extra third, fourth, or sixth cranial nerves. If there was any deviation.
Very relevant. Okay. And you should also mention the eye position, like any proptosis or ophthalmos. Okay, so that also to be mentioned before the eyelids. Okay, fine. So what do you mean by normal position of the eyelid?
Ma'am, a normal position, the superior eyelid usually covers the upper 1/6 of the cornea, whereas the inferior eyelid just touches the limbus or is at the level of the limbus of the cornea, lower limbus of the cornea. Whereas in this case, in the left eye, it is the upper eyelid is present at the level of the superior limbus, hence it is abnormal.
Okay, it means that there's a little lid retraction. Okay, so what are the causes of this eyelid retraction?
Ma'am, one is ectropion.
Eyelid, yeah. If it is in the lower lid, it is ectropion. Upper lid?
It is Bell's palsy, ma'am. Bell's palsy.
Yes,
coma.
Bell's palsy. Tarun is telling overaction of Muller's muscle. Yes. So where do we get overaction of Muller's muscle? Which condition?
Ma'am, Horner syndrome.
Horner's is opposite. No, it will be. So sympathetic overactivity, as in thyroid eye disease. So the commonest cause for eyelid retraction is thyroid eye disease, wherein you get a eyelid retraction. And definitely in this seventh nerve palsy, where the orbicularis is paralyzed, there is an unopposed action of your levator muscle, right? So there is a balance between levator and orbicularis. When orbicularis is paralyzed, there is no counteraction for the levator muscle. So it is pulling more. So that is why we have eyelid retraction in a case of facial palsy. Okay. So the skin, eyelashes, margins are all normal. Okay. So palpebral aperture is more. Yeah. So vertically it is little higher. Okay.
Ma'am, eyebrows, the positions was normal, whereas in the left eye it was drooping. Cilia were normal in both the eyes. Lacrimal apparatus, the punctum was normal in both the eyes. Skin over the lacrimal sac area was normal. On performing Roplast test, it was negative, ma'am.
Okay. So eyebrow position is drooping. That is because of?
Ma'am, probably because of again weakness of the muscles, muscles.
Weakness of your facial muscle. So your frontalis. So the frontalis muscle is paralyzed. So the lid is drooping. The eyebrow is drooping down. Okay. The palpebral aperture, no, it won't be 20. Like 20 becomes too wide. So since it's at the superior limbus, maybe I think it's probably 12, which you have written it as 20. That's okay. Okay,
Yes.
lacrimal apparatus is a very, very important thing to be tested. So what is a Roplast test? How do you perform this Roplast test?
First, take the consent of the patient. Then you apply pressure over the medial portion of the medial canthi of the eyeball of the orbit, and then you check for any regurgitation from the upper or lower punctum. If there is regurgitation, any purulent discharge, mucopurulent discharge, then it indicates that the patient is suffering from chronic dacryocystitis.
Okay. Why is this testing of the lacrimal apparatus important?
Ma'am, in case of cataract surgery or any corneal cataract surgery, then first there is increased risk of post-operative endophthalmitis if a patient is suffering with dacryocystitis too. So to prevent this, first dacrocystorhinostomy is performed, and then the patient is taken up for cataract surgery.
Okay, if you don't do that, they will land up in endophthalmitis. Yes.
Yes.
So that is one thing. And another aspect, in a corneal case, why is it important?
Ma'am, risk of corneal infection, like it progresses further to corneal ulceration, perforation, and destruction of the cornea.
Basically, if there is a dacryocystitis, the corneal ulcer can, even a conjunctivitis can proceed to a corneal ulcer, or it is just that these organisms are Tarun is telling nidus for infection. Very good. So since these organisms are residing very close to the cornea, it causes increased infection. Okay, go ahead.
Conjunctiva. Palpebral conjunctiva were both normal. Bulbar conjunctiva on the left eye showed diffuse congestion. Fornices were also normal, ma'am. Sclera was normal.
Different types of congestion that you know? So you
Ma'am,
have
there
mentioned
is
diffuse congestion. What are the other types?
Ma'am, there is circumcorneal congestion and conjunctival congestion.
Yes.
Ma'am, these are the two types I know.
Okay. How do you differentiate these two?
Ma'am, conjunctival is mainly more superficial, while circumcorneal is deeper. So this one is also bright red, and circumcorneal is dark purple. On application of phenylephrine, topical application of phenylephrine, there is blanching in case of conjunctival congestion, whereas in case of corneal, there is no blanching, ma'am.
Yes. So how is the arrangement of these blood vessels?
Ma'am, it's of the branching type in case of conjunctival congestion, and it's radiating in case of circumcorneal congestion.
Okay. So where do you get the circumciliary congestion?
Circumciliary, ma'am, mainly in case of keratitis, acute congestive glaucoma, iridocyclitis.
Yes. So those are the, so in a conjunctivitis, to differentiate between conjunctivitis and these other things, they will usually, conjunctivitis will not have the circumciliary congestion. So right, but a corneal and a uveal cause will have circumciliary congestion. Okay, go ahead with your scleral and corneal examination.
Sclera appeared normal on the right eye, and left eye it was red in color, appeared red in color. Cornea.
More like your conjunctival congestion, which is visible on the sclera. Are there any specific causes of scleral congestion?
Then surface.
The scleral causes for congestion.
Ma'am, episcleritis and scleritis itself.
So those are deeper congestion. So these blood vessels will be more dark red. They won't be bright red. Okay. Okay. Corneal examination.
Ma'am, the surface was normal in both the eyes. Sheen was normal in the right eye, but absent in the left eye. Shape was also normal. Transparency, right side was transparent, whereas in the left side, there was a loss of transparency. Size was normal in both the eyes. Ulcer was absent in the right eye, while it was present in the left eye, ma'am.
Okay. So you don't have to write, like really write ulcer absent present. You can just write loss of transparency because of a corneal lesion and describe the ulcer. Okay. So how do you know that the surface of the cornea is normal? What tells you the surface is normal?
Ma'am, you do the window reflex test.
Yes,
so here you ask the patient to go to the window, stand near a window and look at a distant object in the surroundings, and you observe the corneal surface from the side. So there, if the window, the grill or the grid pattern of the windowsill is distorted, then it indicates that there's an abnormality in the surface of the cornea. Otherwise, it is normal.
Yes. So that is how you will tell the surface is normal. You can also see your torch reflection, the reflection of your torch also. How does it look? So that also tells the surface is normal. What do you mean by sheen?
Ma'am, sheen is basically luster or
Yes.
luster of the cornea, ma'am.
Yeah. So the shining. So
Shining
the
of it.
wetness of the cornea. So that is the sheen. Okay. Shape.
Ma'am, shape, it's they say it's watch glass shape. Abnormal shape can be keratoconus, which is normally seen in young children with allergies.
So what are the causes for loss of transparency?
Ma'am, first one, like corneal ulcers, corneal abrasions, edema, corneal edemas, any endothelial dystrophies or degeneration, and then any foreign bodies present in the what do you say, anterior chamber. These are
So
the
for
main.
this question, you can also go ahead like telling what are the causes for loss of transparency. The causes associated with the non-inflamed eye, causes with an inflamed eye. So white lesion on the, you can also tell there is a white lesion on the cornea or loss of transparency. So white lesion in a white eye, white lesion in a red eye. So white lesion in a white eye, meaning there is no inflammation. All the causes of dystrophies, dystrophies
Edema.
sometimes can have not the edema, opacities, mainly corneal opacities and corneal degeneration, like your arc senalis, crocodile chagrin. So these all go into the causes of non-inflammatory lesions on the cornea. The causes of red eye and white cornea. So those are all your ulcer, corneal edema, some of the dystrophies, those things. Okay, fine.
Okay.
So can you describe the ulcer?
Ma'am, I've actually drawn a better image in the next few slides.
Can you please show that? Yeah.
Ma'am, so this was the original image. So here we have the eyelids. Along
Yeah,
with that,
wait a minute. So generally in your corneal ulcer case, we expect you to draw a diagram. So just make a simple line drawing like this, which will give a better idea about the location of your ulcer. Okay, yeah, go ahead, Avanish.
ma'am, so here we find that the eyelids are normal, but there's matting of the cilia. Then there is also a diffuse congestion with both circumcorneal as well as conjunctival congestion. In the cornea, we see that in the inferior quadrant, there is an ulcer, which is around 2 into 3 millimeter in size.
Okay. Okay.
Then this is how the corneal, which is present in the inferior quadrant. Should I go back to the previous table?
Yeah. So see, the cornea can be divided in like this into 9 quadrants. So you can tell if the ulcer is in the center, you can tell it's present in the central quadrant. If it is in the inferior, you can tell inferior quadrant, medial part, superinasal area, inferonasal area. You can also use clock hours to describe the ulcer. So the ulcer is present from 5 o'clock till about 6:30, 7 o'clock position. So that is how you describe the ulcer. Okay. Go ahead with back to your case.
Ma'am, then on examination of the anterior chamber, depth was normal and there were no, it was clear. The anterior chamber was clear.
Okay, what are the abnormal contents that you can get in the anterior chamber?
Ma'am, they can be hypopion, that is mainly pus that is collected in the anterior chamber, hyphema, which is blood that is collected, then pseudohypopion, which is basically cancerous cells that are present in the anterior chamber. Ma'am, and sometimes even silicone oil, which causes an inverse hypopion that can be seen there.
So that is also present. So what are the different depths of the anterior chamber? When you tell normal, how do you tell that the depth is normal?
Ma'am, you take a torchlight, ask the patient to look forward, take a torchlight and place it on the temporal side of the eyeball or temporal side of the cornea. If there is an arc of light that is present here on the nasal side, then it indicates that the chamber, that the depth of the anterior chamber is normal. In case there is a shadow, then on the nasal side, then it's called as an eclipse sign and indicates that the depth is reduced.
Okay, tell me some causes for a shallow anterior chamber depth.
Ma'am, shallow anterior chamber causes are hypermetropia, then intumescent cataract, phacomorphic glaucoma.
Yes. Tell me some causes for irregular anterior chamber depth.
Ma'am, annular synechiae, like irregular
So whenever
segmental.
there is synechiae, you can get irregular. Some places it is deep, some places it is shallow, some places it is normal. Causes for deep anterior chamber.
Causes for deep anterior chamber, ma'am, myopia, aphakia, then keratoconus, keratoglobus.
Go ahead.
Yes. Ma'am. So now the pupil, ma'am, there was only one pupil. It was circular in shape, 3 millimeter in diameter, and it was central in location. On performing pupillary reflex, both direct and indirect reflexes were normal in both the eyes. Digital tonometry was also
performed direct light reflex. Pupillary examination. How do you do that?
Yes, ma'am. Ma'am, so you first
are we audible? Hello. Avanish, can we hear you?
Ma'am, I can hear you, ma'am. Can you hear me?
Yeah. Okay, fine. Okay. So go ahead with your digital tonometry. In corneal ulcer cases, you have to be very, very careful. Can you hear me?
Yes, ma'am. I can hear you, ma'am.
Yeah. Why you have to be very careful in corneal ulcer cases? You can even tell I have not performed digital tonometry also. Why is it?
Ma'am, because in corneal ulcer cases, there'll be thinning of the cornea. So there is performing digital tonometry increases the
Okay. So risk of perforation. Because of the risk of perforation, we may even avoid doing digital tonometry in a corneal ulcer case. But you have to tell, I have not performed digital
perforation of the corneal epithelium, which is to, ma'am.
Yes.
Ma'am, can you hear me?
Yes, I can. There was some lag. Okay, in a corneal ulcer, avoid doing digital tonometry. Mention that you have not performed for this reason of perforation, risk of perforation. Okay, lens.
Ma'am, it was normal in position and shape. Color was grayish white and it was transparent in both the eyes, ma'am.
How can grayish white be transparent? It may be grayish black.
Grayish black. Sorry.
Grayish black. So once you tell grayish white, it becomes a cataract. Okay, extraocular movements.
Ma'am, it was normal in both the eyes, both uniocular and binocular.
Okay. So very relevant in this case. Okay, go ahead. Next.
Then systemic examination. CVS S1 and S2 heart sounds were heard and there were no added sounds. Normal vesicular breath sounds heard on auscultation of the lungs, both the lungs. Abdomen was also normal. CNS examination. Motor system was normal. Sensory system was normal. Cerebellar system was also normal.
Whatever is abnormal.
Ma'am?
Just tell whatever is abnormal. Any particular...
Ma'am, only on cranial nerve examination, 7th cranial nerve, there was an abnormality in the function because there was loss of wrinkles on the left side, drooping of the eyelids on the left side, along with lag of thalamus. Also, the patient was unable to blow his cheek on the left side with loss of nasolabial fold on the left side and deviation of the mouth towards the right side when he attempted to smile or when he asked him to smile. Okay.
So what is your provisional diagnosis?
Ma'am, on the basis of the given history and clinical examination, I think it is a case of exposure keratitis in the left eye, secondary to cranial nerve 7 palsy.
Okay, so you have to mention left eye in the diagnosis. No, you have to mention left eye. Okay. So right eye, what is with the right eye? You can also right eye is normal. Okay.
Normal.
So in most of you will write the involved side. You should also mention diagnosis of the left other eye also. So other eye also you have to mention. Okay. What are the differential diagnosis for your case?
Ma'am, neurotropic ulcer, that is
Yes.
another differential diagnosis since he had a history of stroke. So there could be involvement of fifth cranial nerve too. But based on this, it's highly unlikely. Based on the history and examination, it's highly unlikely. Then,
So how do you check the corneal sensations?
ma'am, so first is you take a sterile cotton swab. Then you make it into pinhead or pinpoint shape. Then you take the consent of the patient and you check it at 4 quadrants, so five areas of the cornea: superior, inferior, medial and lateral, or nasal and temporal, as well as the central part of the eye. And if there is, so then you touch the tip of the cotton swab towards the cornea at the near the limbus. That if the patient blinks, then it indicates that the fifth cranial nerve function is normal.
Okay.
Otherwise,
So
it is there is a lesion in the or decreased sensitivity of the fifth cranial nerve.
Okay. One thing that you have to keep a note is that you have to check the both the eyes with different cotton wisps, or you have to check the normal side first and then go to the other side. Because if you check the infected side and use the same wisp to the other eye, you may spread the infection. That is one thing. And also ensure that you don't stand directly in front. It has to come from sides so that you avoid that menace reflex. Okay. Yeah. So that's how, if at all your corneal sensations are decreased, it could be neurotropic ulcer. Since the sensations are normal, and there is a lag of thalamus, we are favoring more of exposure keratitis. Based on the location of the ulcer, can you tell what the different types of ulcers?
Ma'am, if it is central in location, then it would be a neurotropic ulcer. Whereas if it's located more peripherally, then it can be exposure keratitis or even a bacterial or corneal ulcer too.
Okay, so
Bacterial.
central means it is more of a neurotropic. Inferior location means exposure keratitis. If you have multiple ulcers, that means it's mostly fungal with satellite lesions. Geographic ulcers, yeah. So these are like the whole area. It could be a geographic ulcer. If it is in the limbus, like the peripheral limbus, it could be any of the immune-mediated ulcers, like fascicular. I mean, any of the immune related, like okay, so those are the based on location of different ulcer. How do you tell? Okay, so how do you want to how do you differentiate a fungal corneal ulcer from a bacterial ulcer versus this exposure keratitis?
Ma'am, so bacterial and exposure keratitis can be differentiated from bacterial and fungal by the absence of hypopyon, as well as mainly by the absence of an hypopyon and any infective changes that are usually seen. Bacterial and fungal ulcers can be differentiated by the shape of the hypopyon that will be seen in the antechamber. In case of bacterial, it will be flat, whereas in case of fungal, it will be dome shaped, ma'am.
Yes. So can your exposure keratitis go into a bacterial or fungal ulcer?
Yes, ma'am. It is a possibility because the corneal epithelium, which performs the main mechanical barrier function for the cornea, is damaged here. So there is a risk of infection from an exogenous source, which can lead to a further infection, which can convert it into bacterial corneal ulcer and develop.
Okay. So one mnemonic that you can easily remember to differentiate a bacterial and a fungal corneal ulcer is DEFGHI. Okay. So D stands for dry looking ulcer. E means elevated edges. F for feathery margins. Then G for gray color. H for a large hypopyon. I for an immune ring, and S for satellite lesions. Okay, DEFGHI and S. Okay, so like that. So a bacterial will be the opposite. So this is dry, that is a wet looking ulcer, and then elevated, these are like a depressed edges. Feathery margins, there we do not have, we have sloping edges, and gray color in fungal, yellowish white in bacterial. No immune ring. The hypopion is dome-shaped in fungal. In bacterial, it is. How is the hypopion different in fungal and bacterial?
Ma'am, it's dome-shaped in case of fungal, whereas in bacterial it is flat, ma'am.
Yeah, and also
Or
the
sometimes-
consistency. It is thick and it is very thin, mobile and non-mobile. Okay,
Mobile and non-mobile.
so it's mobile in a bacterial, it's non-mobile, and sterile. Whether organisms are there in this hypopion or not.
Ma'am, in fungal, organisms will be present. That is, it is non-sterile. Whereas bacterial, it will be sterile, ma'am.
Okay, so these are the different ways you differentiate. Okay, how do you want to manage this patient?
Ma'am, so first.
Wait a minute, Avanish. So here, just go back. So many times students, what they do is they'll end your case sheet at this. So you write provisional diagnosis and end the case sheet. So don't do that. After your provisional diagnosis, do spend another half page or so writing differential diagnosis and management. So in management, you write investigations and the treatment. So what other investigations do you want to do for this case?
Ma'am, complete blood count, total leukocyte count, as well as a differential leukocyte count, ESR, as well as C-reactive protein, then blood sugar levels.
It's very important is your blood sugar levels to see if this person is prone for infections. What ocular investigations can you do?
Ma'am, fluorescein staining, ma'am. Fluorescein dye staining of the to localize the defect as well as to determine the extent of the corneal epithelial defect. Okay.
So how does the you can also use a rose Bengal stain also. You can either use a fluorescein or a rose Bengal stain. Fluorescein is less painful for the patient than a rose Bengal. It causes more stinging. So how does this the stained cornea look like?
Ma'am, you check it under a blue filter. So then under that filter, it appears green in color, ma'am.
Yes. So what color is fluorescein as such? What color is the strip?
Orange. Orange.
Yeah. So the color of the strip is orange. When you stain, it appears bright green or apple green when seen under a blue filter. Okay, 3 colors are involved: orange originally, a blue filter, and apple green. Okay, so you see SPKs. So those are superficial punctate keratitis. Okay, you are going to see. So these spots are not visible to the naked eye. So these small spots can be seen on fluorescein. So whatever is your ulcer, further to this visible area, what are all the other areas that are affected? That is known by staining of your fluorescein. And you should also do the lacrimal syringing. Although you have done a Rho plus, you should also do lacrimal syringing in this case. So management, the
treatment, ma'am. In this case, it will be any artificial teardrop installation and installation of ocular ointment, bandage during sleep, then soft bandage, contact lenses also can be placed. Surgical management is mainly temporary tarsorrhaphy.
Okay. So artificial teardrop, what is the frequency that you will tell them?
Ma'am, 4 times a day.
Yeah, so depends on the extent of the affection. If it is less, you can ask 4 times. If it is more, you can even ask them to use hourly. So since we are using it hourly, you have to give a preservative-free artificial teardrops, because preservatives also can cause some epithelial problem. It will interfere in healing. So you can give preservative-free eye drops. So you can give an antibiotic drops also as a prophylactic use. Okay. Bandage during the sleep, how do you ask the patient to do this? Just keep that slide. Okay. Avanish, keep that slide. Yeah. Why do you want to bandage the eye during sleep? Can we?
During the activity throughout the entire months of. Ma'am?
Why do you want to bandage the eye during sleep?
Ma'am, during sleep, there is no voluntary control over the orbicularis oculi muscle. So as a result of which the eye will be continuously open, which will then lead to further drying and desiccation of the cornea. So to prevent this, you can just bandage the eyes, and this will create an occlusal surface over the cornea and also spread the tear over the entire cornea as well as the conjunctiva. This automatically reduces the drying and desiccation over them.
So this is a very, very important modality of like just a simple measure to avoid further worsening. So I want all of you to note this, because most of you will be working in the ICU when you become interns, and later in life also you will be attending a lot of ICU calls. So many of the patients who are in coma or little less conscious, they will not having adequate lid closure. So ensure that these patients the eye is closed with a bandage or an eye patch, so that these patients who are normal do not go into exposure keratopathy. Okay, so this is a very important thing that all of you have to know. Okay, soft bandage contact lens.
Ma'am, that contact lens will be held in position mainly by a film of tears over the cornea. So that will further prevent the drying again and drying and
Any
reduce.
problem with using the soft contact lens? Any
Ma'am, there is risk of it breaking and disintegrating, which can then cause damage to the epithelium and worsen the condition.
Generally, they don't break, but then any foreign object on the cornea is a nidus for
Nidus of
infection.
infection. Yes.
So basically, you have to be watchful when you're prescribing soft bandage lens, because they can cause infection. So when do you want to do a temporary tarsorrhaphy?
Ma'am, when the conditions, when the keratopathy or keratitis is worsening or is not improving for a long time, then you can do a temporary tarsorrhaphy, which will then, which is a reversible procedure, and ensure that till the discretion of the ophthalmologist, they can keep it, and then afterwards remove it and check for whether the healing has occurred or not, ma'am.
Okay. When do you do a permanent tarsorrhaphy?
Probably following an enucleation procedure.
No. Like this, when usually your Bell's palsy will improve with time. But if at all, if it's secondary to some surgery or anything, non-healing also. Okay, Aditya is telling non-healing also. So in most of the patients, temporary tarsorrhaphy, we anticipate that the facial palsy resolves. When the facial palsy has been there for more than 6 months, 1 year, then we go ahead with the temporary tarsorrhaphy. Suppose that makes the eye look very small. You can also use something called as a chemical tarsorrhaphy. You can also inject botulinum toxin to the upper lid to give rise to a chemical tarsorrhaphy. Just paralyze the levator muscle so that the eye is paralyzed for 2 to 3 months till the ulcer is healed. That is another way to treat. Any other modality to get the eyelid down other than this tarsorrhaphy? Patient is cosmetically conscious, long-standing facial palsy because of surgery, it's not going to improve, or eyelid retraction in thyroid. So you can use gold weights. So gold weight on the upper lid can also be used to just bring the eye a little lower. Okay. So coming back to our diagnosis, exposure keratitis. So here, this patient, we know that it is secondary to a facial nerve palsy. Are there any other causes which can cause your exposure keratopathy?
Ma'am, coma, lag of thalamus, then symblepharon, as well as ectropion. Ma'am. Yes. Ectropion also is another cause of exposure.
Aditya is telling proptosis. Yes, so that's another cause, proptosis. That's why I told in the initial thing, we should rule out proptosis. So thyroid eye disease is particularly prone for exposure keratitis because there are two things. One is the you can have eyelid retraction. Along with that, you can have proptosis. So both can contribute together to cause exposure keratitis. Okay. I think that is with the exposure keratitis. So are there any questions that you people want to discuss? Also, what are the causes for facial nerve palsy? What are the other causes?
It can be divided into central as well as peripheral causes. Central causes are mainly any stroke, pontine hemorrhage, multiple sclerosis involving the brain stem. Then peripheral causes, ma'am, they can again be divided into intracranial, intratemporal, and extracranial causes. Intracranial causes are mainly acoustic neuroma, schwannomas of the facial nerve, any metastasis over the cerebellopontine angle. Then intratemporal, ma'am, are mainly Bell's palsy, Melkerson syndrome, fracture of the temporal bone,
I
neoplasms.
think that's enough. Okay, so basically in your exam, we just want to know whether you know the causes. The moment you give a systematic answer, we know that you know the answer, and we'll go ahead with the next question. Okay, fine. I think we can end the session. If are there any questions from the viewers?
No, madam, no doubts, sir.
Okay.
If you have any doubts, you can post it in the YouTube chat section. We will get it answered. Okay. Excellent presentation, Avanish. Really extraordinary. This
Really.
discussion shows the caliber of a BMC student, and also, of course, the teacher of BMC, how they should be when the students are like this. Excellent presentation. Okay, one of the very rare presentations I've seen after a long time. Such a wonderful presentation, Avanish. I thoroughly enjoyed the way you answered to the point, and so confidence in you. Everything. It was better than any PG level also presentation. Madam, what about you? What do you say?
Definitely, Avanish. Even I was not expecting this level of answering. It was really very good.
Okay. Thank you, ma'am. Thank you.
No, you are extraordinary, Avanish. Take it from me. You are really extraordinary. You are going to reach next level height. Okay.
Yes. Thank you, sir.
Keep up the spirit. Okay, and especially next year, keep presenting cases like this. I'm looking forward to more presentations from you. Okay.
Definitely, sir.
Okay, do well in your upcoming exams. Okay, and your first impressions already made. 99% Chinmayee madam is going to be an examiner. So, okay.
Yes, sir. Yes, sir. I know.
Okay. And see, because of a good, well-prepared presentation like this, we all could learn a lot. See, madam asked all levels of questions. The entire topic so nicely covered. The way you answered, no, especially most of them answer fact-based questions. But when madam asked why you apply that soft bandage, everything, the way you answered, no, that shows you have understood the concept very well. The way you assimilated and way you answered, no, it was really brilliant and extraordinary. I should admit it. Thank you once again, madam. The discussion was too good for all of us. I thank Chinmayee madam and Mr. Avanish and all the active members for this fruitful discussion. Thank you once again.
Thank you very much.